Sleep apnea, a better sleep for a better you. Today we're joined with Dr. Jordan Brunson, who's going to share with us a little bit more about sleep apnea, the importance of not only individuals getting screened and getting treated for it, but also making the importance of oral health providers, our colleagues, being trained on how to diagnose and how to treat it as well. Dr. Brunson, how you doing, man?
I can't complain. It's a good day in Georgia. How are you, sir?
We doing okay. We wish we had some good weather where we're at, but it's all good. It's all good. We inside, so we good. We good.
I'm with you there. I'm with you.
So please share a little bit more about yourself for those that are meeting you for the first time.
Well, first off, I'd like to say hello to all of our future colleagues, current colleagues, and training colleagues, future doctor. My name is Dr. Jordan Brunson, but we're going to dispense with the doctor thing because it's going to be a whole lot of doctor stuff. So I'm just Jordan for the purposes of this podcast. Originally from Dallas, Texas. For after high school, came to Atlanta for my first stint, went to Morehouse College. After Morehouse, I was lucky enough to go to the University of Michigan School of Dentistry, be there with Dr. Todd Esther and some other people that are familiar when you see the Michigan folks walking around NDA. After that, I was on scholarship for the Army, so I did a stint at Fort Benning, which is now Fort Moore in Columbus, Georgia. After Fort Moore, I was an associate for a couple years in Columbus and then purchased a practice in a little town right outside of Atlanta called Palmetto, Georgia. For those of you familiar with Atlanta, Palmetto is south of Fairburn, north of Noonan, off Interstate 85. That was my first practice. Currently, we have 4 practices, all under the Palmetto Family Dental brand in Palmetto, Georgia, Zebulon, Georgia, McDonough, Georgia, and Fayetteville, Georgia. And I also practice sleep apnea treatment through a company called Palmetto Sleep. So right now we're co-located with the 4 offices as far as seeing patients. We have an admin office in Griffin, Georgia for Palmetto Sleep. So, married, have 2 daughters, 9th and 7th grade. So far, nobody wants to be a dentist. So we'll see what happens.
Yeah, how about that? Same
Yeah.
thing in my household too. Nobody
Mhm.
was thinking about oral health at all, but that's okay. That's fine.
Yeah. We love
So
them anyway.
yeah. So this topic, sleep apnea, let's jump into it because for many
Mhm.
people, it's not fine, right? It's not a fine
Mhm.
thing. Some are walking around, don't even know they have it or have some of the characteristics and some of the items that can cause them to have it. So let's make sure that we go through this and both for providers and also for individuals so they're a little bit more educated about it, but also helping them with the condition. So what is sleep apnea? A very ABC elementary type of
um,
description.
I would say as an early description without diving into certain things. Sleep apnea is a disorder in which your breathing stops and starts. I mean, it's basically as simple as that. Sometimes it's accompanied by snoring, but it's not always accompanied by snoring. Sleep apnea has 3 basic types, but really most people need to concentrate on 2. One is obstructive sleep apnea, or OSA, and that's just sort of like it's caused by relaxation of your throat muscles or another obstruction over your airway. And then there's central sleep apnea, or CSA, and that is basically malfunction with your cranial nerves talking to your throat or sometimes your diaphragm, basically telling you not to breathe functionally. But that comes from your brain. There's a third type that's newer called treatment emergent or central sleep apnea. And that's been shown that there are a few cases where people have obstructive sleep apnea. And with that obstructive sleep apnea, they have, during their treatment, they've developed central sleep apnea. So technically, it started out as obstructive sleep apnea, and now they're having a nervous condition where the sleep apnea is coming from their central nervous system now, not just an obstruction over their airway.
So that sounds good for us.
What do I
us
tell the
as
patients?
providers. Yeah, that
For the
sounds good for us.
patients,
But
for the
some of the
patients,
patients, they probably are like, okay, am I obstructed? Am I just, why, I'm my spouse or significant other, partner, or myself, I hear myself snoring. Like, is it, does that mean I have sleep apnea? So like, how is it that people are typically coming to your office inquiring about this condition? Is it based on the fact that people are hearing them snore? It's causing a rift in the bedroom or the sleeping quarters. Like, how are people coming to you based on what they think or may not know about sleep apnea? Hey everyone, it's Dr. Darwin. Just want to take a quick break from this episode and hope that you are enjoying it. First thing I want to ask is, did you know that a large majority of the individuals like you who watch these episodes are not subscribed to the channel, to the YouTube channel? Nevertheless, we want to say thank you for watching and continuing to share these videos and episodes with others. Next, I want to say is subscribe. Yes, please hit the subscribe button so that you get these notifications each time these episodes are released. Last is I wanted to connect with those of you who are seeking to become an advanced dentist and specialist. And I invite you to our next event called the Get Into Dental Residency Challenge. This is a special 4-day event that will give you direct access to the mistakes that you want to avoid when you're applying to residency programs, and also the 8 steps that you also want to avoid so that you do not have an unsuccessful application submission. The information that we will be covering over those 4 days will be some of the tips and strategies that I teach in my one-on-one and group coaching trainings with clients who are continually and successfully being matched into and selected into high-profile residency programs here in North America. So if you're pursuing or aspiring to get into dental residency this application cycle, this challenge is for you. Check out the link below to receive more details and join the challenge. And also, I would encourage you to enroll in the challenge via the VIP experience. The VIP experience gives you actually access to a 1-hour Q&A session every day of the challenge before we actually get started with the challenge. And it guarantees me to answer your specific questions that you and other VIP experience members have on a daily basis. So I'll see you in the Get Into Dental Residency Challenge, and let's get back to this episode.
So I would say you want to start with low-hanging fruit first. You don't necessarily need to open and say, hey, I only want to treat sleep apnea, or I'm going to start a sleep apnea company. For most people, I started with the hygiene exam. So I looked in hygiene, and in some research and stuff, I had seen that, wear facets, mandibular tori, reddened gums showing mouth breathing, reddened tonsillar pillars, things that were like some signs that I could see every day that would trigger me to ask a patient, hey, do you snore at night? Has anybody ever told you you snore? Or do you wake up with headaches? Or do you have are you going through the day and you're tired, or can't make it through the day? You can fall asleep anywhere. So I would ask questions like that. If you do it enough, you can almost diagnose people walking through the mall. I mean, I diagnosed myself. I was diagnosed, but it's just kind of like, hey, this is what's going on. But there's a few things you should look for. But one of the main things is overweight or neck thickness over 17 inches. That's characteristic. Now, I'd say that's more of a male characteristic, but it is a huge characteristic. The loud snoring, observed episodes of your breathing stopping and starting, the gasp, as I call it, especially when you're sleeping. Waking up at night a lot with the feeling of gasping or choking, and trouble focusing, and like I said, just not being able to ever feel rested, like you could just fall asleep at a stoplight. So, those are some of the things that we're seeing, and that's what comes now. Now we're at the point where we're getting people seeking us out to treat sleep apnea. But when we first started, it wasn't that way. We were telling people. I sat through a course right after I got out of the military that said the problem in oral health, or the quest in oral health for the 20th century, was occlusion. Everything was occlusion, occlusion, occlusion. You could almost, say, hey, this symptoms or this irreversible pulpitis started with, that cusp tip hitting wrong or things like that. Whereas the 21st century problem is going to be airway. And so that is one of the things that first made me start looking into the sleep apnea. For patients, generally, I will tell them, because they're coming to us for an oral treatment. And the reason why that's important for our industry is, for a lot of people, the obstruction in obstructive sleep apnea has something to do with your tongue placement, or your tongue like drifting back over your larynx or your throat, causing your airway to be cut off. Okay, so your tongue placement is what's causing a lot of this. So the devices that we use are normally a mandibular advancement device, which will lock your tongue position forward, which keeps your airway open. Keeping your airway open allows that breathing to happen without positive pressure, which I'll probably talk about a little bit in a second. But for most of our patients that we're seeing, we just kind of talk to them about, from a layman's term standpoint, everybody's tongue is a car, your teeth is a garage, and some people's cars is too big for the garage.
Yeah.
So we have to move that garage. Okay. So
Yeah,
because that car is the car.
now that's a great analogy. I like that. And
Mhm.
and that's also related to what you're finding, or what the condition, how the condition displays itself, intraorally, and just
Mhm.
overall too. Like you said, there's some external characteristics with size of the neck and snoring that people are hearing. Um, um, why is it that, you mentioned that, and I love that you mentioned that this is the number one uh and top 21st century oral health clinical problem, right? Number one oral
Mhm.
health clinical problem of the 21st century. Why is it a must that individuals get evaluated, or get treated, or at least get screened for sleep apnea?
This is one of those things that we as dentists, a lot of times I think we see ourselves, the patients come in and say, they almost want to talk to us like we're a mechanic, for lack of a better term, like, hey, just fix this tooth. I don't care about it. Like, they don't see that everything is connected. But in this instance, when we're treating sleep apnea or airway management, everything is connected. If you do not treat this, you're at increased risk for stroke, increased risk for high blood pressure, increased risk for certain cancers, including uterine cancer, lung cancer. You're at increased risk for being in certain accidents. There's certain industries that you have to do this. If you're an airline pilot, if you are a truck driver, if you're a train driver, a lot of these accidents you're seeing on TV, somebody fell asleep, literally. The trains that crash, it seems it's always somebody that fell asleep. They fell asleep because they have sleep apnea. They were tired on the job, and they, for whatever reason, weren't diagnosed or wearing their thing. Most of these industries are setting standards now that you have to be evaluated to even get the job. And the evaluation is annually to make sure whatever adjunct you're using to support being cured or treated in this fashion is still working at an optimal level. Because there are 3 different levels of sleep apnea. Okay. And so you don't want somebody who's got mild sleep apnea being treated on the same level as somebody who has severe sleep apnea. So it's kind of a function of how bad it is, how well we can manage it, our different ways of managing it. But to ignore it, basically, you're looking at shortening your life. And for us, especially as African Americans, it's something that really goes untreated, like heavily. And what you'll see is if you look back, I got curious. This is a year or so ago, I got into ancestry stuff, and it's interesting how much of a record some of these things, people keep records of things. And so I looked up the autopsy from my great grandfather. I was like, okay, my grandfather's autopsy. All these people died of massive heart attacks. But I remember all these people snoring through, like, heavily. Okay. They all dropped out in their mid 70s, which now, if you ask somebody and they say they died and they say, how old were they? 74? People say, what happened? Whereas 30 years ago, somebody died when they were 74. People said, oh, yeah, they lived a good life. Now 74 means you checked out too early. So this is one of those things that is I'll call it a mild treatment that will buy you 10, 15, sometimes 20 years extra of life. So that kind of things like that is why you must get tested. And from a patient standpoint, most of our patients have been in a high pressure situation. But what I generally try to tell them is your body is conditioned to respond to stress in a certain manner. So what you're putting yourself through every night is, imagine there was a tiger in the corner. I left this room and an actual tiger appeared in that corner. Your fight or flight response, you'd have an adrenaline rush. You'd be ready to either run if there was a way to run, or you got to fight the tiger. I said, what's going on is, depending on your scores on the sleep test, you're doing that 20 times, 30 times, 50, 60, 70 times an hour. You're having that. Because when your body stops breathing, that's what makes you start breathing. The adrenaline rush wakes you up, you breathe, and then you try to go back to sleep, and then 10 minutes later it happens again. But all that constant stress, that fight or flight response you're going through multiple times nightly, especially over years, it kills you. That's what happens. You burst a blood vessel. So that's why it's important that everybody gets tested.
Yeah, and that waking up all the time doesn't allow you to sleep, and like you said, goes back to people not sleeping, people not being rested, causing injuries on the job, even at home as well. And it also sounds like there's a direct, if not significant, connection to systemic health. I mean,
Yes.
that's what we're really talking about as well. Something that, a condition that originates in the oral cavity for whatever reasons, and it, due to anatomy, due to other things, and it's causing an effect on the rest of the body. So very important to make sure that individuals get evaluated or screened for it, or at least we as oral health practitioners, as part of the healthcare team, are asking these questions. screening for these specific questions, many of which patients don't even realize that maybe they are at higher risk for just based on their lifestyle, right?
Exactly.
Which is key. And you mentioned one of the things that typically it sounds like it's done as part of the diagnosis, and you mentioned a sleep test, right? Um, and I'm sure after that, there's some other steps that go on to the different diagnoses and the levels of sleep apnea that a person will have. Tell us a little bit about what are some of the typical treatment modalities that are related to making sure that individuals can breathe through the night, get rest, and don't have any comorbidity related to other chronic diseases that are already maybe they may be suffering from or are already at high risk for. What are some of those treatment modalities? Keeping in mind that it requires collaboration, right?
It does. And depending on where you live is going to depend on how much collaboration it requires. What we have, I think, first off, let me say, you need to check your state laws. So I'm going to talk about Georgia, which is, I think what I do in Georgia would work just about anywhere, but there are going to be some states where you don't have to jump through as many hoops. So let me say this. In the state of Georgia, I cannot diagnose you with sleep apnea as a dentist. You have to be a board certified sleep medicine physician to diagnose sleep apnea in Georgia. So what I do is I see certain things that are going on in your oral cavity, or you might have answered certain questions on your new health history, or you were referred to me from the sleep physician. And in that case, that's great because I don't have to go through this. But if you came in off the street and I'm like, I think you might have sleep apnea, here's what I do. Okay. My first step is to say, are you interested in treatment for what we both are pretty sure might be going on here? Patient says yes. I set them up with a telemedicine visit with a board certified sleep physician. I use a company called Dedicated Sleep. Most of their sleep physicians are in Chicago. There are a few elsewhere, but most of the time, this patient is being treated by a physician in Chicago, technically, even though it's telemedicine, so it's a Zoom call. They do that visit with the physician, takes about 30 minutes on they're scheduled in. After that, the physician says, look, this is what I think is going on. I want you to do a sleep study with them. We set them up with a home sleep study. They take home, it's a ResMed AirLink is what I use. That sleep study, it takes about, you're going to sleep with it for the night, obviously, but I'd say on average, you're going to do, I need about 4 to 5 hours of sleep for a good reading on that sleep study. But the way that the ResMeds work is it's going to be like a belt around your chest, and there's a pulse oximeter on your finger, and there is a nasal cannula that's showing your breathing. And a couple of things that it's majorly measuring are your blood oxygen level, your respiration rate, and the amount of times you're stopping breathing throughout the night, which for insurance purposes, they're really looking at a number called the AHI, which is the apnea hypopnea index, which I'll go into in a second. Once that comes back, the sleep physician meets with them a second time. After that visit, the sleep physician will say, hey, yes, you have sleep apnea. In some instances, they're referring them for CPAP. In some instances, they'll refer them back to me for a mandibular advancement device. If that patient does not want the CPAP, they can say, I do not want a CPAP, or I've tried before, or I just don't want to do it. Some insurance companies require them to try for 3 months. Some don't care. So if they don't care, you don't have to worry about the the 3-month process, you can just go right into a mandibular advancement device. But if they do care, you do need to be in that CPAP for a little bit. After that, they come back and see me. In the state of Georgia, I am a durable medical equipment provider, so a DME provider. I work with most major medical insurances. I work with Medicare, not Medicaid, but I work with most major medical insurances. And in that instance, I fit them for the mandibular advancement device. I follow them for a couple, and that's just a basic, it's a scan. I mean, I use Trio scanners. And then I record their bite. And after that, I maybe follow them 2 or 3 times to see how they're sleeping. Once they report they're sleeping restfully, I will set up a second sleep study with their sleep physician. And after that, they're basically treated. Um, for patients that are involved with this, though, I'll say they're treated with a caveat, because obviously, if they have to go see you, Dr. Hayes, or if they have to go in for heavy perio, get a new implant, anything like that, they have to get another device. So I always tell them, this is your device for now. It's not necessarily forever. If you have any new crown and bridge, if you have certain types of fillings that are changing the shape of basic teeth, if you have ortho treatment, you're going to have to get another device made because your teeth have changed. So that is a big one with us. Now, for like some of the numbers, okay. Sleep apnea, it's like 3 different levels, okay. So that AHI number is your events an hour, your apneas or hypopneas, or you're stopping breathing for that hour, how many times that's happening. If you're between 5 and 15 times an hour, that's considered mild. If you're between 15 and 30 times an hour, that's considered moderate. Anything more than 30 is severe. For what we do as oral healthcare providers, generally speaking, you only want to see people that are mild or moderate. When you get into severe, and I do have some patients that are severe, once you get into severe, you're just trying to change that F to a C plus. But the patient understands that, because the problem is, for those patients, they absolutely will not wear a CPAP. And if you won't wear a CPAP, wearing what we're making, let's say your AHI is a 60 and you wear oral advancement and it gets you down to a 20, that's still taking you from severe to moderate, which is better, okay? It's not the best, but it's better. And we as dentists generally are thinking we have to fix something 100%. You don't go into somebody's tooth, do a root canal, leave a canal and say, well, I hope that works. But physicians, God bless them, but they do this a lot. It's like if you go in for back surgery, they'll tell you, it's like, I can reduce your pain by 20%. There's no way that I could go to a patient and say, I'm going to do something to that tooth and you'll still have pain, but it'll be 20% less. We just can't get away with that. Patients want us to be fixed 100%, but you have to think about this from a medical standpoint, and you're just trying to improve that health number. So I want to bring the AHI number down. Am I going to bring it down to 0? I have. Do I do it every time? No. Sometimes I take it from 15 to 8. Sometimes I'll take it from 20 to 2. You don't know, but the important part is you're going to bring that AHI number down.
Well, that's good. And for all the technical folks, there you go. You got some stats on the numbers from the sleep study. But you also mentioned, related to this, you also mentioned one key fact that, again, is just part of the landscape and the ongoing landscape, and differences yet similarities between oral health and overall health as far as medicine and dentistry, which is there's collaboration that is needed, that is required, and especially depending on state licensure and where you are and what the regulations are for dentists and also for medical providers, right? Physicians rather, and all of those regulations are noted in your state board documents, regulations, rules and regulations. But there's also one part, and I'm not sure if this is state regulated, but I think it's federal related, which is being a durable medical device provider.
Mm-hmm.
And how that is also uniquely related to getting paid.
Mm-hmm.
Right? Explain a little bit and share a little bit about that designation and that process of being, if you're going to be doing sleep apnea therapies and treatments and collaborations with folks on the medical side, the importance of getting that distinction of being, I think you said DME provider, a
Mm-hmm.
durable medical device provider, and how that's key to allow you to make the device that, or components of the device that we will typically use as a treatment modality for as a oral health provider.
I think we as oral health providers, when you're used to dealing with, let's say, dental insurance is, even though from our end it's this daunting, confusing thing, it is elementary school compared to medical insurance. Medical insurance is insane, and medical insurance. There's people that have a master's degree in coding. I mean, it's crazy the amount of things that go on here. But um, I will try to keep it as simple as I can. But if you want to be paid, especially by the federal government, you have to be a licensed DME provider, which you can do by registering on the web. Um, it's regional. I will say if you're in the Southeast, it's a group called Palmetto GBA. Actually, I have no idea what GBA stands for, but it's Palmetto GBA. And you go on the website, you register. It takes, they come out and look at where you are. They check all these, make sure your I's are dotted, T's are crossed. It's some hoops. It's the government, so there's a lot of paperwork. Once you get through that, you have to stick. They're very, very, these people are sticklers on dates, rules. So I'll give you, for instance, there's 500 million different types of sleep apnea mandibular advancement devices. From the government standpoint, you can only use those on what's called the PDAC list, which basically it's a government list of, it's for pricing. PDAC stands for pricing, data analysis, and coding. But basically, it's a list of devices that the government says are good enough to be charged out for Medicare. Why this is important is the government paying entity, which for most people is Medicare. The insurance companies piggyback off of that. So you're following this Medicare checklist, but Blue Cross wants you to do the same checklist. United wants you to do the same checklist. So if you're you find this lovely device that you love using and it's not on that PDAC list, they will not pay. Or even worse, sometimes they will pay and then they find out that you weren't using the right thing, then they'll ask for their money back. That's a bad day. But at the end of the day, you have to make sure what you're doing is on that PDAC list. There is a very, very popular device that I don't personally use, but I do still sometimes have to diagnose, or not diagnose, but treat with. It's called a hertz. Now, I do a ProSomnus Evo hertz on a lot of my Medicare patients or some of my private insurance patients, but they can't use what's called a regular Evo because it wasn't PDAC approved. Now, we just got it PDAC approved like a couple months ago, but up until a couple years ago, 3 years ago, there's no way I could have used an Evo on those patients because the government saw it as not good enough. Now, it was good enough for me. I've been wearing it. Most dentists, everybody loved this ProSomnus device. But if you put one in a Medicare patient, they wouldn't pay for it. So you could use it for cash paying patients and certain other things, but for insurance patients, you had to use the tried and true method that's been working for 20 years or whatever. So all that to say, you have to apply for those Medicare and government programs and things online. That is one of the ways to get paid. Now, also, unlike dental insurance, which I tell people is sort of like stuff in a tube, it's not crazy in medicine to be 90 days out before you get a check. Whereas when I look at my dental, I want most of my AR, you know, I don't want to get past 30, but I definitely don't want to get past 60. If it's at 90, I'm probably not seeing that. It's like red flags. Whereas medical is like, if it's 90 days, that's nothing. Like, this is normal. You get paid, and it's almost like, oh, I forgot I did that. I did that in, September. But, that's a normal medical thing. So from a dental standpoint, you have to be prepared to wait on that money. It's not like dental where, in 3 weeks, you're going to get a check back from Blue Cross or Delta Dental. So it's a different way of doing things. You have to kind of know, you have to be prepared to, I guess I'll say, embrace a financial hit when you first start doing it, knowing that the payoff is at the end, but it's not nearly as quick a payer as dental insurance is.
Man, this is a lot. And I'm glad we're having this discussion because as people are listening, they're probably also wondering and thinking, like you just said, there's a lot of components that go into treating this very important and chronic disease that people have that some may not even know that they have it going on. From being getting a license to be able to be designated as a durable medical device provider to having to collaborate with our colleagues on the medical side, to being educated enough to know or educated in how to screen and what things to screen patients on as they're coming into the office, or whether they're being referred or whether they are genuinely just new patients. It's a lot. It sounds like a lot. And even though this is, airway is the hot topic in oral health, it's also a topic that sounds very complicated,
Mhm.
or it can be very complicated. So, what type of training is going to be best for individuals, our colleagues that are listening, watching, for them to complete and continue to learn for those that are getting into sleep medicine and airway issues? What's going to be what are some of the ways that we can learn more about all of
Mhm.
these different details, not on the clinical side but also on the business side, right? Dealing with payments, dealing with CMS, dealing with things related to your board, and the collaboration with other providers as well.
So I think the easiest way to answer your question is, first off, let me say this is my answer today. Okay. I don't know what my answer next year will be. You'll see me at the Hitman and I'll say something. I'll be like, oh, that class is, don't do that one anymore. But today, um, this is sort of, I don't want to say it's as bad as the Wild Wild West, but it is not like there's a bunch of residencies and things like that. This is very, I don't want to call it cutting edge, but it's a very hot topic, but it's a ever flowing, very moving topic. So there's no 100% answer, but I'll say this: if you want to start, um, the American Academy of Dental Sleep Medicine is a good place to start. They have a couple online courses that can spoon into some in-person stuff. They do an annual meeting. That's very good. I've done that. I've done ProSomnus, which is the mandibular advancement device company I really like. They do an annual conference. I've done that. There is, as I said, the dedicated sleep. They also do an annual conference. where you meet with the sleep physicians and things, discuss topics. So done some of that. And I also really, really, really like study groups. An airway study group, it's sort of almost like a unicorn thing. You have to kind of ask around, and you might be the one that starts a study club. But we happen to have one here in the Peachtree City area where we try to get together. It's few dentists, periodontists, sleep physician, orthodontists, and we kind of
Med?
talk shop.
Any med folks?
Sleep physician. There's a sleep physician. There's a sleep physician, and actually there's a pulmonologist that just started with us too. But what I will say next, I guess, is it's sort of a tangent, but it might pique some people's interest a little bit more. Okay, so this actually, one of my friends, this is like started in a random way, but I will speak for, I know a lot of Black men. We have, when you look at, shaving and razor bumps, and people say, like, do you shave wet? Do you use an electric razor? Like, how do you shave? And one of my friends who's a historian said, have you ever looked at old pictures of us? There's no such thing as razor bumps. And I said, you know what? So I started looking at some old pictures. There's no razor bumps. Like, where did razor bumps come from? Razor bumps are like a new thing because people are using these crazy chic blades, right? So, you got 4 or 5 razors and we cut our skin too close. But if you use I just use a regular razor, I don't have razor bump problems. But what that tangent went in with dentistry is several things that we do now were not problems before. There was no orthodontist in Renaissance France. There were no orthodontists, or malocclusion was not a large problem in Senegal in the 1800s. A lot of these problems that we're treating and dealing with now, to include the narrowing of the face, which goes to our problem with airway, tongue size, car versus garage, are modern problems. And they're problems that develop, I think, out of a modern diet, just being perfectly honest. Okay. And there's a group called the International College of Craniofacial Orthopedics that studies a lot of this. And it talks about how the changing of the human skull over the years, the shortening of people's mid-face, the narrowing of their jaws and palate, when you compare skulls of now to skulls of 100 years ago, 300 years ago, 400 years ago, how this is affecting, basically our everyday lives and livelihoods and the amount of time we're on this earth. So even though it sounds like a tangent, it has a lot to do with why I liked the airway. When you look at 40 years ago, I'm sure there was ADHD in schools. I mean, I think when I was in elementary school, if you were active, if you had attention deficit disorder, they just said you were bad. They gave you Paddling and you went on your way. There was no Ritalin readily available. But when you look at the reasoning behind and some of the things that go on, some of the misdiagnoses that have been done, a lot of these kids that have ADHD, they have airway problems. When you look at their eyes, they're red. Imagine if you didn't sleep well for a week, you're irritable. These kids ain't slept well in years. So they are hyper. Because if you gave them good sleep, they would mellow out. Sometimes that comes from, changing their growth pattern to widen out their palate. Sometimes that comes from like doing I'm having a brain fart, tongue release. You a tongue release that allows better breathing. It also allows the tongue to rest on the roof of the mouth, which widens the palate, keeps narrowing going down. The other one that ICMO, which is that International College of Craniofacial Orthopedics, is studying, a big one, unfortunately for our orthodontist friends, is the amount of people walking around here that have had their premolars taken out. Once upon a time, people had room for there was no third molar wisdom tooth removal that just happened everywhere. When I was in the Army, we basically thought there was no such thing as a good third molar. All third molars were taken out. Okay. But a couple hundred years ago, everybody had room for their third molars. Nobody had space problems. Nobody really had crowding issues. Why do we have that now? I mean, what is it about our modern world that has changed so much? And it's environmental, but I'd say it's diet, just my personal opinion. Now, the other thing that you have going on is when you remove those premolars and you get that lovely, nice arch form and that beautiful smile, you still made the garage smaller. It's pretty. It's a nice garage. You're in Buckhead. You're in Potomac. Okay. But it's a small garage. And guess what? You still got a big body Range Rover. You are not driving a Mazda Miata. Okay. So how are you going to fit that Range Rover in that little garage? You can't. So we almost gave you sleep apnea by it by making your arch form better, making your smile better, but your tongue was still the same size. So we actually gave it to you. We're seeing that more and more, especially as a larger percentage of the population can afford braces. Okay. So that's a problem we're running into. The issue with the kids is a problem we're running into. But when you look at it over a whole, over time, even, there is a study I was reading about this indigenous group in Brazil in the Amazon forest, and it is a woman's job monthly. They switch it off because the way that this group looks at children is that the mother is the mother of all the children. So even though you only got two kids, all the kids in that village are your kids. So you sit up at night, and if a kid snores, they hold their jaw forward. And they literally hold it there every time they snore until basically their physiology kicks in and they don't do it. And they say it normally takes a month or two. Okay. But they do that because if you're a loud snorer, which anybody who's been in the military knows, if you can't snore, especially when you're a forward unit, you give your position away. They're looking at it from the standpoint, if you're a warrior, you can't snore. If you're hunting, you can't snore. I mean, it's these are things it wasn't meant to be, but they're looking at it from a practical application. But it's something that they've figured out and cured,
Right.
or in their way. Okay, so there are different ways we're looking at it. Palatal expansions. Obviously, from a sleep apnea standpoint, losing weight is huge. So this Ozempic, Monjaro wave and stuff, it's really affected some of our patients, which from a good standpoint. Now, I will tell you the flip side of the curve, which I don't know you personally, but I'm sure there's people on that are listening to the podcast. People look great, and then they stop taking Ozempic, and they have an Oprah problem. You need two closets of clothes.
Yeah.
Because when you stop taking it, you lost 40 pounds and you stop taking it and you gain 60 pounds.
Yeah. Well,
and
like
I've seen that happen a lot.
Well, yeah, and that's going to be an ongoing discussion because there's probably still not enough research behind it. Just like there's ongoing and evolving research and learning for these airway conditions and sleep apnea as well. Tips, advice, knowing what you know and the things that you've been doing over the last several years, and focusing a component of your business and your health service on airway management and sleep apnea. Knowing what you know now, what are some tips and advice that you want to share for those providers, future dental providers that are, dental students and residents that are training now, that are continuing to advance the fundamental curriculum and information that they're learning as students, and as they continue to learn more through continuing education? What are some tips and advice that you would give them as they are looking and how to address this this chronic condition that's going to be continue to plague us in this 21st century in oral health?
I think the main issue is to not become complacent. You have to be a lifelong learner, especially if you're going to deal with this. I do think you do not want what I believe is the future to pass you by. So even if you don't want to treat it, which I totally get, it's like some people just love doing ortho, some people love doing perio. I don't expect you to be good at everything and be able to treat everything, but I do expect you to be able to discuss it, especially when your treatment of certain patients will affect their airway. Depending on what you are doing, whether it be a tongue release, you might need to have them see a myofunctional therapist first, or enduring. You have to do some therapy with that tongue release, just like you would if you had a knee surgery. And you have to be able to discuss that. If you are doing something, with the orthodontics, and you do know this, like, you know what, in order to make this look right, we're going to have to take some teeth out. That's fine, but you do need to be able to educate the patient and say, look, these are some things that can come out of this. These are some things, yes, your smile is going to be great, but if your, husband, wife, mother, father, whatever, say now that when you're breathing at night, it's heavy or you're snoring, stuff like that, we need to get that treated. If it's something as simple as, hey, on hygiene checks, I need to be looking at these patients, they're now saying, I remember even when I was in dental school, when people said that somebody was a bruxer, it was, oh, you have stress, or, something was going on in your life, or, maybe your occlusion was off. That's why you're bruxing. 90% of the time now they're saying bruxing is an airway problem. When you're bruxing, when you're clenching, when you're grinding, you're trying to keep your airway open. You're doing what a mandibular advancement device does. You're trying to interlock your teeth so that your tongue does not drift back into your airway. That's all you're doing. That's why you're clenched. And so that added pressure from the clenching is what gives you those class 5 lesions. That's what gives you, the mandibular tori, palatal tori, just that pressure, the bone laying down to deal with the pressure that you're putting on those teeth at night, trying to keep your airway open. So I would say, if nothing else, you have to remain diligent. You have to, maintain a certain level of knowledge in order to discuss some of these topics. You don't want to go to any discussion like totally oblivious of the topic or the subject matter. But anytime you see something in the community or you can engage somebody, I would tell you to do it. There aren't a whole lot of people doing it right now. On the low end, people think it's anywhere from 12 to 30% of our entire adult population. So that's anywhere from 35 to 120 million people walking around here with sleep apnea. So even if everybody started doing it, there still wouldn't be enough of us to deal with it. What has really boomed, or I'd say boom as a negative in this instance, is that the CPAPs are not functioning well. The sound dampening foam that they put in them is either disintegrating, causing particle issues, or it is disintegrating and being broken down into carcinogens, including formaldehyde. They're constantly being sued. If you stay at home during the day and watch TV, if you are on a CPAP or if you drank water at Camp Lejeune, you can sue somebody. So neither one of those things have been working out quite well for the manufacturers, both ResMed and Philips, who maintain most of the CPAPs in the United States, are under severe lawsuits right now. When you have a CPAP, if you've ever seen one, it's a tube and a mask. There's multiple types of masks. There's the tube is normally the same, but it's a plastic part, so it has to be changed out. It has to be changed out every 3 to 6 months. So maintenance costs are high on insurance companies. So one thing that we're trying to get them to understand or try is that doing oral or mandibular advancement first, especially on mild and moderate cases, should be the standard, not a CPAP directly. CPAP directly for severe. But what they've done for us is always like, let's try the CPAP, and if that don't work, let's go to mandibular advancement, where, you know, we're less invasive. Just from a small, quick topic, there is a third treatment that's currently, I wouldn't call it the rage, but you'll see people advertising it. It's a surgery called Inspire, which involves basically putting a electric lead on one of your cranial nerves to, they don't use that term, but I'd call it jolt your muscles awake, or jolt your muscles into spasm. At night, they normally show the commercial. It's all like this peaceful thing, and you put a remote control next to your heart, and oh, you turned it on and you're good. The problem, in my opinion, with that is it's invasive. It's a surgery. I mean, as much as they want to say it's a small surgery, I mean, they're cutting around your neck. I don't know if I want that, but I would try something else first, is my point. So, yeah, those are the three. Us with mandibular advancements, CPAPs, Inspire. In the past, several ENTs were doing a lot more. It's a surgery called a UPPP, but basically thinning out your soft palate, taking out your uvula. I mean, it was a very radical surgery. The problem is it would cure snoring for, 3 months to a year or so, but most patients reported the snoring came back. Once the scar tissue, healed up and everything like that, that scar tissue was tight. So there was nothing to vibrate for that snore sound. But once that scar tissue loosened up and everything like that, and you could get vibrations in that soft palate, the sound came back. Mandibular advancement does not treat snoring. It treats sleep apnea and airway issues. However, when you do the advancement, when you open up that airway, I'd say 85 to 90% of the time you are looking at that snore level coming way down or being eliminated. But that is not why we're in it. So I tell patients, I'm not here to eliminate your snoring. I'm here to increase your breathing and increase your overall well-being in your wakefulness. But a side effect of that is you'll probably stop snoring. So it's not a snore guard. I'll say that.
Sounds good, man. Well, this has been very helpful, man. A lot of details, a lot of information still evolving on the topic, and definitely a topic that I know a lot of us and our colleagues and even patients are starting to see more of, right? More inquiries, more things out in public, more inquiries and discussions in the dental office as well. So this has been great. What's the best way for people to get in contact with you and your team doing all of this amazing work?
You can reach us multiple ways. Our phone number is 770-230-0222. We're at palmettosleep.com. So PALMETTO sleep.com, palmettosleep.com. And you can reach me at DRB, like Dr. B, at palmettofamilydental.com.
All right, man. Hey, thanks so much. There you have it, guys. Latest update on sleep apnea and the #1 chronic oral health clinical condition, 21st century, sleep apnea. Hope this has been helpful. And go to the next video. Go to the next video. Go right now.